way under stress, and surgery and anesthesia is indeed a stressful condition. So when these chemical messengers are not optimum and undergo a chaos, then it is a real problem. So for today's webinar, I would like to welcome our esteemed chairpersons, Dr. R.D. Patel, sir. I'm privileged to introduce him. He is famously known as R.D. sir. He was a professor emeritus at anesthesia with us at KSHGS Medical College and KEM Hospital. Sir is well known for his surgical skills, airway management. He has several chapters and publications to him. He must have probably done more than hundreds of thyroids and parathyroid surgeries and n number of insulinomas throughout his career. Thank you for accepting our request and joining for this webinar, RD sir. Next chairperson is Dr. Anita Shetty. She's all known for her humbleness, She's a professor and head at HBT Medical College and Cooper Hospital, several publications and international publications. She has past president and secretary of ISA, past president of ISNAC. She's a neuroanesthesia fellow teacher and a number of publications to her credit. And we also have Dr. Sameer Rege. He's a surgeon, professor and unit chief. Laparoscopic and endocrine surgeries are his specialties. He's with GS Medical College and KEM Hospital. He's a national and international faculty. He's known for his laparoscopic skills. The first lap Whipples was done by him in West of India. The first transoral endoscopic thyroid was done in West of India by him. He has been awarded the Young Surgeon Achievement Award by Gastrointestinal Foundation Forum. So let's start today's webinar. I will request Dr. Anita Shetty, madam, to please introduce us first speaker.
Good evening. Can you hear my voice?
Yes, ma'am.
Yeah. Thank you, Shraddha, for giving me this invitation, for the kind words. Now, the first speaker is Dr. Unmesh Bidekar, who is an DNB neuroanesthesia. He has 10 publications. He's a faculty. He has been a faculty for TCI workshop at ISNAC 25. Right now, he is working as a consultant in Wockhardt Hospital, Mumbai. His topic is, can you put up his topic? 1 minute. Mastermind malfunction, that is anesthesia management of pituitary tumors. So welcome, Unmesh, for this talk.
Yes. Shall we start?
Yes, you can start.
Good evening, all. So in this tri-lecture series, we'll start with anesthesia management of pituitary tumors. Now, often when we are in a neuro operating room or any operating room, you may come across an MRI report like this. So this patient is having complaints of left-sided blurring vision since 2 years, and the MRI brain is showing a lesion arising from the pituitary gland into the supra and paracellular region. They have given the dimensions. It is suggestive of pituitary macroadenoma. It means that it is a lesion of more than 1 centimeter size or 10 millimeters. So it is a pituitary macroadenoma. Again, they have given the surrounding anatomy. That is, it is closely abutting the cavernous splenoid and supraclinoid segments of both the internal carotid arteries and A1 segments of the ACA. There is also a mass effect and stretch of the optic chiasma, which is draped along the superior margin. It is compressing the floor of the third ventricle. So when you get a MRI finding like this, it is obvious that this patient will be posted for pituitary macroadenoma lesion excision. So now there are 2 surgical ways to remove this lesion. One is a transcranial approach, which is a little morbid approach, and one is a transnasal endoscopic approach, which is being used now to deal with such type of lesions. So whenever you read such a report, your plan of anesthesia management must be ready in your mind. Now, when you say that the lesion is closely abutting these important vessels, it will be feasible to take an arterial line in local anesthesia, and keep blood grouping and cross matching available in case of any emergency. So with this short introduction, we'll start with the topic. So when we think of pituitary tumors, they can be divided on basis of size or basis of functionality. So functional adenomas are, if it is a ACTH secreting, it is due to Cushing's disease. If it is a growth hormone secreting lesion, it is due to acromegaly. And then other hormones may also emerge like prolactinoma or TSH adenoma or gonadotroph adenoma. And then the non-functioning adenomas are null cell adenoma and silent corticotroph adenoma. Now, apart from this functionality, you can classify these tumors based on the sizes. So less than 1 centimeter is microadenoma, more than 10 mm or 1 centimeter is macroadenoma, and giant adenomas are more than 40 millimeters in size. So we'll start with the basic anatomy. As we know, pituitary gland is a P-shaped gland, 500 mg in weight. It rests here in the sella turcica, which is a midline depression in the sphenoid bone. Now, above it is the optic apparatus, including the optic chiasm, and the roof is formed by the diaphragm sella, also known as the fold of the dura. Now, inferior and anterior walls, it is laid along with sphenoidal sinuses, and the posterior wall is formed by the dorsal sella of sphenoidal bones. So as we can see, these various important vascular structures like the cavernous sinus, the intracranial carotid artery, they lie in close proximity to the pituitary gland. And so while excising the gland, if there is a damage to any of these major vessels, there can be torrential bleeding, which has to be dealt with. So if you consider the MRI image and the anatomy, even though the gland is small in size, its approach and its peculiar placement, it makes it difficult for anesthesiologists to do this case. So the pituitary gland lies outside the blood-brain barrier, and as we know, it consists of two lobes, anterior lobe and the posterior lobe. So the anterior adenohypophysis, it produces and secretes hormones regulated by the hypothalamic releasing hormones, and the posterior neurohypophysis, it releases the hormones secreted by the hypothalamus. So the HPA axis functions through this, and the pituitary stalk contains the portal system and connects the hypothalamus to the pituitary. So we should pay a little more attention to the posterior pituitary physiology, because the hormones released here are the antidiuretic hormone and oxytocin by the hypothalamus via the supraoptic and paraventricular nuclei. Then they are transported via the pituitary stalk and stored into the pituitary posterior area. And the end effect site organ is the kidney, where the water reabsorption happens. Now, why it is important? Because damage to this segment leads to diabetes insipidus, and excess release leads to SIADH. Coming to blood supply, the superior hypophyseal artery supplies the adenohypophysis, and the inferior hypophyseal artery supplies the neurohypophysis. Now, the superior artery initially forms a capillary plexus around the hypothalamus and then gives rise to portal vessels, which form a secondary plexus around the adenohypophysis. This system plays a major role in transporting the hormones from the hypothalamus to the anterior pituitary. And the venous drainage, that is the hypophyseal veins from both the lobes, drain it into the surrounding cavernous sinuses. So how will the patient present to us? There can be local mass effect symptoms. They can be hormone hyposecretion or hypersecretion syndromes. Sometimes the patient is asymptomatic and it is purely discovered because of investigations done for any other conditions. Acromegaly, if present, these are pituitary adenomas causing growth hormone hypersecretion. So there are specific anesthesia concerns relating to patients presenting with acromegaly. If there is ACTH hypersecretion, there is Cushing's disease. So any pituitary tumor expanding into the intracellular space can cause this mass effect. Now, what the mass effect will present to us is with headache and visual changes, classically bitemporal hemianopia. and reduced visual acuity. And pituitary gland compression, that is hormonal hyposecretion syndromes such as panhypopituitarism, DI, or other endocrine insufficiency syndromes can be presented with. One rare life-threatening emergency with loss of consciousness, headache, visual defects results from hemorrhage or infarction into the pituitary gland. This is known as pituitary apoplexy. So this is a brief clinical picture suggesting what acromegaly looks like. So basically, excessive growth hormone production after epiphyseal closure is acromegaly, and the same condition occurring before puberty is known as gigantism. So we as anesthesiologists are dealing with airway day in, day out. So acromegaly presents and complicates the airway because of soft tissue and bony expansion. There can be associated kyphoscoliosis, prognathism, macrognathia, macroglossia, pharyngeal and laryngeal tissue hypertrophy, and recurrent laryngeal nerve palsy. So all these features will complicate the patient right from mask ventilation itself. Along with it, 25% of the patients may have thyroid goiters, which may lead to tracheal compression as well. Now, how is their heart? So these patients may present with refractory hypertension, LVH, IHD, cardiomyopathy, biventricular dysfunctions, arrhythmias, and impaired glucose tolerance. So they have associated cardiomyopathy. So a preoperative screening for 2D echo assessment to assess their ventricular function and pulmonary artery pressures is to be done. Owing to the difficult airway, 80% of these patients may have OSA, which may present with right heart failure as well. So all these are airway and 2D echo considerations in acromegaly. Again, what is Cushing's disease? If there is excessive ACTH production or hypercortisolism, it is known as Cushing's disease. So these patients present with central obesity, gastroesophageal reflux, metabolic disturbances, and also they are associated with diabetes, hypertension, and LVH. Now, as we know, obesity and proximal myopathy, which also is associated with it, complicates the ventilation. This condition generates a prothrombotic state, which increases the venous thromboembolism susceptibility. So also these patients are on preoperative cortisol lowering therapies, and there can be metabolic complications of hypercortisolism as well. So what should be our focus of a pre-anesthetic workup? So we have to identify the endocrinological manifestations of the pituitary. What is the hormonal imbalance of the patient? So if there is hyposecretion of pituitary hormones, there can be compressive effects due to a pituitary adenoma, hemorrhage into the gland, and a syndrome known as Sheehan's syndrome, which is pituitary infarction in the postpartum period. So all these are causes of hyposecretion of pituitary hormones. So as I said, there are two surgical approaches. One is a transcranial approach, which is not used now. And the gold standard is a transsphenoidal endoscopic approach, which follows the natural path of the nasal passage. It gives a panoramic view of the region with good visualization using angled scopes. So this endoscopy gives a magnified surgical field and a good image, which is also less invasive. So the surgeons operate from either side of the patient and also from behind the head during microscopic resections. So this approach can cause hemodynamic instabilities, which we should manage. Also, there can be limited access to the airway because of the ergonomics and with the imaging equipment setup. So long extension lines, long circuits should be in place as the head end is away from us while doing these cases. So as the endoscopy proceeds, we should know the pathway from the nostril till the pituitary tumor, what all structures have to be traversed. So from the nostril, the scope enters the nasal cavity and an access is made through the sphenoid sinuses into the sellar floor, crossing the dura where the pituitary tumor is reached. And after excision, sellar reconstruction is also done. So what are the surgical goals in this surgery? That is to ensure as far as possible complete tumor resection without damaging the surrounding vital structures while preserving the normal pituitary gland. We also have to preserve the optic apparatus and avoid the surrounding ICA injury and prevent CSF leak while doing so. So after seeing the surgical goals, what should be our anesthesia goals in these patients? So there are different surgical stages which require attention from anesthesia point of view. So these are critical surgical stages and time points. So first is while the nasal cavity is being prepared with nasal infiltration, we have to blunt that sympathetic response by short-acting beta blockers, or you can use loxicard or adequate analgesia. Then comes sphenoid drilling, where immobility is of utmost importance. During cellar opening, the blood pressure has to be stabilized. We have to ensure optimal surgical field during tumor dissection. Sometimes they ask for hypotensive anesthesia to prevent bleeding and to get a good view. But while reducing the systolic blood pressure, the map should not be compromised. While doing the cavernous sinus dissection, we have to be ready for ICA injury, and hence that blood grouping and cross matching will help, because in case there is a damage to these vessels, you cannot run for blood at the final moment. Again, during reconstruction, you have to prevent coughing, and during emergence, you have to ensure a smooth recovery, a good emergence, because you have to check for an early neurological examination, especially the visual acuity has to be checked whether it has worsened or not, or is it the same as pre-op or it has improved. So for that, to check the visual acuity, the patient should be in his senses, and so a good and smooth emergence is important. So as we have seen in acromegaly, the airway is a challenge. There is a risk of 4 to 5% increased difficulty in airway. Therefore, all equipment necessary for difficult intubation should be available. Regarding face mask ventilation, always keep a LMA standby, because if you are not able to ventilate, you can at least put in an LMA because of the soft tissue overgrowth. Appropriate size mask airway should be available. All the masks airways should be available. So some articles have mentioned that first line technique for tracheal intubation of acromegaly should be video laryngoscopy itself, as you are anyways anticipating a difficult airway. And with even if there is a laryngeal involvement also, planned awake tracheal intubation can also be a good option. In fact, it is preferable to emergency use during failed intubation under GA, because then it minimizes the airway related catastrophes. You can use a reinforced tracheal tube. It has to be placed away from the operating site, because the surgeons, they stand on the right side of the patient and they prefer to go through the right nostril, and then the orotracheal tube comes in their way. So it has to be placed on the left angle of the mouth. So this can be done by using a special left-handed laryngoscope, the photo of which I will show you at the end of this seminar, in which you do not need to basically change the side of the tube, because you are intubating the patient. I mean, the laryngoscope is placed in the right hand and you are putting the endotracheal tube from the left hand. So it is just a minor modification of our normal intubation techniques, where you are using a specially designed left-handed laryngoscope blade. So your the blade or the scope is in the right hand and tube is in the left hand, because you want to place the tube on the left angle of the mouth. So after intubation and checking the ventilation, throat packing is a very important step, because to prevent the bleeding into the glottis and entry of the blood into the stomach, which precipitates post-operative nausea, vomiting. So whenever you are using throat packs, you have to loudly say that throat pack has been inserted. You have to note down the time. Sometimes you can place a label on the forehead that throat pack is in, and similar steps have to be taken while removing the throat pack. After thorough suctioning, remove the throat pack, keep good suction ready, and announce to the entire team that the throat pack is out. So regarding additional monitoring, apart from routine monitoring, you can do this procedure under TIVA. So you need depth of anesthesia monitoring. Urinary catheter, even though it is just a 2 hour or a 1 hour procedure, it is must because these patients may land up in DI. We have to go for invasive arterial pressure monitoring, preferably under local, because there are frequent hemodynamic changes, because there is proximity to the carotid and cavernous sinuses. We have to do an Allen's test. We have to ensure good collaterals, either by ultrasonography or an Allen's test, because in acromegaly, there can be distortion of the anatomy. And you have to properly fix the arterial line because the skin of the patients is also thick. So proper fixation is necessary. If you are working in a new setup with new surgeons and you are not sure, then it is better to place a central venous catheterization because you cannot run at the end moment. If not, then good two wide bore IV accesses are okay. You can proceed ahead. Supine position with 20 to 30 degrees head up will improve the venous drainage and it is beneficial. And also you should take care of positioning as the head can be placed on a horseshoe headrest. So these are all the additional monitoring and precautions that need to be taken. So there are some specific manuals in this procedure. That is, for an invasive adenoma, sometimes a lumbar drain is put at the beginning of the surgery to minimize CSF leak. It reduces the pressure at the site of surgery. It also allows injection of NS, which promotes the visibility of suprasellar tumors through transmission of pressure in the CSF column. And then lumbar drain has to be put post GA in lateral position to minimize the chances of vasovagal attacks. Valsalva maneuver is done to improve the visualization of the tumors, especially in suprasellar extension. Here you can check for CSF leak and ensure hemostasis. So all these are specific maneuvers in endoscopic resection. Coming to some specific role of drugs, etomidate, as we know, it inhibits alpha 11B hydroxylase, which reduces the cortisol synthesis. So unnecessary etomidate should not be used in ACTH deficient patients. Also, we have to avoid etomidate in severe HPA axis suppression. Regarding steroids, different institutes have different protocols. And the important thing here is serum cortisol is checked on post-op day 2, and then the maintenance regimes are guided accordingly. But hydrocortisone 100 mg at induction, followed by 15 mg in the morning and 5 mg in the afternoon of post-op day 1 can be given. Diabetes mellitus and pituitary. So sugar control is important. Stricter regimen of insulin has to be employed to control hyperglycemia. And for this perioperative hyperglycemia, sliding scale can be used. All OHAs have to be stopped on the day of surgery. And any perioperative hyperglycemic episode, you can use IV regular insulin. Post-operatively, there can be refractory hyperglycemia, which has to be again managed with sliding scale of insulin. Another important concerns are extubation concerns. So at the end of the surgery, as we discussed, throat packs have to be removed. The airway has to be cleared of blood and secretions. Here, the patient is at greater risk of airway-related complications in places like acromegaly, class 3 obesity, BMI more than 35, patients having sleep apnea. So here you can use some exchange catheters, which will benefit for extubation. Again, smooth emergence is essential. Why? Because we have to prevent coughing, minimize bleeding, prevent dislodgement of fat graft, prevent CSF leak. Another important criteria is early neurological assessment. So long-acting opioids you cannot use short-acting opioids and drugs with having short half-lives. Smooth emergence may be achieved with low-dose remifentanil for this purpose. LMA has to be kept standby because post-extubation there can be airway compromise. And you cannot give excessive positive pressure with face mask ventilation as it may precipitate CSF leak, pneumocephalus, and bleeding. So wherever there is risk of CSF leak, we have to avoid CPAP. And if at all there is post-operative hypoxemia, you can go for high-flow humidified oxygen through a face mask, because direct nasal application of any catheters is to be avoided for at least first 6 weeks. Post-operative, look for CSF rhinorrhea and diabetes insipidus. You reduce the risk of CSF leak by using stool softeners, avoid straining and nose blowing for up to 6 weeks post-surgery. There can be central transient DI and hence an hourly urine output measurement has to be done. So you have to look for signs of fluid balance, urine and serum osmolarities, and electrolytes. And appropriate fluid therapy has to begin to replace the losses if DI persists. So this is the image of the left-handed laryngoscope blade, which I use to intubate these patients in order to save time in changing the tube position. So at the end of this lecture, these are 3 to 4 salient points which we should take home. One is always inform while putting and removing the throat pack. Tube to be placed on the left side. Suction should be meticulous. While instilling local anesthesia, blood pressure is bound to shoot up. So you have ways to control it. You better opt them. And most important thing which I feel is pre-operative counseling has to be done that the nose of the patient is going to get blocked. And post-operatively, the person should use an open mouth for breathing. Otherwise, the patient becomes more anxious in the peri-extubation and post-extubation period that is not being able to breathe through a blocked nose because there is a dressing put on both the nostrils. Thank you.
Thank you,
Mish, for that excellent presentation. Shall we take Anita Madam, RD sir, do you have any questions on this?
No, it's a very...
Do we take the question now or in the end?
Ma'am, in the end.
At the end, we'll take at the end.
Okay.
Yeah. RD sir, I request you to please introduce our second speaker, Dr. Isha Singhal.
Okay. Can you hear me?
Yes, sir, we can hear you.
Next speaker is...
Isha, can you share your slides, please? You're not able to see. Yeah. See.
Now I can see Dr. Isha Singhal. She is working as an assistant professor in St. James Medical College and King Hospital. And her achievements are she has fellowship in pain medicine, FIAPM, executive committee member of Society of Study of Pain in Mumbai, and areas of interest pain management and difficulty. So you can start your presentation.
Thank you, sir. Thank you for the introduction. So the topic that I've been given today is anesthesia management, or is it? It's not moving ahead. Okay. So the topic is anesthesia management of insulinoma. This is a rarely discussed topic, and our roadmap for today will be, we'll go through a case, the epidemiology, the symptoms, coming to the diagnosis, and then our anesthesia management, which will include preoperative, intraoperative, and postoperative care. So to begin with, we have a patient who is a 48-year-old female homemaker. She has been having recurrent episodes of giddiness, loss of consciousness, and she has had 2 episodes of query seizures in the last 2 years. So finally, after going to multiple doctors in one private setup, she was diagnosed to have hypoglycemia. Her past history was not significant. There was no diabetes, hypertension, asthma. And because of these symptoms, she had undergone a detailed psychiatry evaluation. So a lot of times, because of such symptoms, they go to a psychiatry evaluation, and because a definitive diagnosis is not made, they are labeled as PSY. Then in her personal history, her diet was mixed, bowel, bladder, sleep was all normal. Family history, there was no similar complaints in the family. So after coming to KEM, she was started on tablet prednisolone, 20 milligram Moody, Levera, 50 milligram BD, and she was already on olanzapine. So on examination, she was conscious, oriented to time, place, person. BMI was slightly raised, which is a common finding in such patients because they have a insulin secreting tumor, which leads to high insulin causing hypoglycemia. And because they have symptoms of hypoglycemia, they end up eating more to feel better, to pass their symptoms, and resulting in a high BMI and weight gain. So there was no pallor, icterus, cyanosis. Her per-abdomen was normal. RS, CVS, CNS was not significant. Her investigations were also within normal limits. She was admitted under endocrinology and was diagnosed as insulinoma. And in all such patients, they generally rule out MEN1. So what is an insulinoma? It is a rare pancreatic neuroendocrine tumor of the beta cells. It periodically secretes excess amounts of insulin causing hypoglycemia. So what is said is that mostly this insulin secretion, it occurs during fasting stage or after exercise, but it can randomly occur because the tumor can periodically secrete insulin at any time of the day. So it might not be related to fasting also, but generally they have a very low fasting blood sugar. Then the incidence is very rare. It is 1 in 2 lakh. Then it has a rule of 90%. 90% are pancreatic, 90% are small and solitary, 90% are benign. Only few of them are associated with MEN1 syndrome, and these are generally malignant also. The median age of presentation is 47 years, and it is most commonly seen in females than males. And we have also seen most of our patients have been females of middle-aged females. So coming to the common symptoms of hypoglycemia, which they have, there can be neuroglycopenic symptoms and adrenergic symptoms. So in the neuroglycopenic symptoms, the most common one is altered mental status like giddiness, unconsciousness episodes, which is present in 80% people. Then visual disturbances. This also we have seen commonly in patients, and we generally get a ophthalmopinion done preoperatively to rule out any other organic cause. Then they can have amnesia, coma, abnormal behavior, and sometimes seizures also. Coming to the adrenergic symptoms, most commonly they have sweating, that is very common. Then they have weakness. They will say kamzori lagta hai, chakkar aata hai, or kapkapi lagta hai. So tremors, palpitations, and almost 50% of them are obese. So we will have the challenges of obesity also. So how do they diagnose insulinoma? This is Whipple's triad, which is used for diagnosis. So the patient will have all these symptoms that we have discussed of hypoglycemia. Then there has to be a documented low plasma glucose at that point of time when the patient has symptom of hypoglycemia. And after administration of glucose, there is symptomatic relief. So it is simple, the Whipple's triad. Then how do we make a definitive diagnosis? The gold standard is a 72-hour fasting test in which the patient is admitted to the hospital for a supervised fast according to protocol. We measure the glucose, insulin, C-peptide, hydroxybutyrate, actually sulfonylureas, and a few more levels. And what is the result is, see, when we measure all this after a 72-hour fast, actually what should happen is there should be low glucose and there should be low insulin. Insulin should almost become less than 6, or almost you can say it should not be produced. But in these patients, the glucose levels are less than 2.2 millimole per liter. That means approximately less than 40 milligram per deciliter. Serum insulin levels are high. So they are approximately 10 micromole per millimeter. And C-peptide, which is secreted as a byproduct of insulin secretion, is also high. So all these are diagnostic of having a insulinoma. So this is done for patients to diagnose insulinoma. Now the surgeon will get done a CT scan, a MRI, and a endoscopic ultrasound to finally find the position of the tumor. And endoscopic ultrasound has high sensitivity. Now coming to the management of an insulinoma, generally surgical resection is the treatment of choice. So laparoscopic enucleation is done in our center most commonly. Rarely ever open surgery has been done. It's always been laparoscopic. By the time they are being scheduled for surgery, they can be on medical management. So the medical management dietary will be starch corn-based diet. One important drug is dioxide. Commonly, the patients are on diazoxide. It blocks the insulin secretion via ATP-sensitive potassium channels. And we have to be careful of the side effects of these drugs, which is fluid retention and nausea. The second drug that they can be on is octreotide, and this directly binds to the receptors on the insulinoma and decreases the insulin secretion again. So these patients can have bloating, cramping, and oral steroids are obviously commonly given to these patients to maintain glycemia. And now we come to the main part, that is the anesthesia management. So what are our anesthesia concerns? First thing is they can be morbidly obese to obese. Second thing, because of multiple dextrose infusions and multiple times their IV lines have been taken, they can have a difficult IV access or thrombophlebitis. Then our goal is to manage blood sugars between 100 to 149 or up to 180 is also acceptable. Then to prevent hypoglycemia. The main two goals of anesthesia are that until tumor resection, we have to avoid hypoglycemia and we have to prevent rebound hyperglycemia post-tumor removal. A multidisciplinary approach, which involves a surgeon, anesthetist, and an endocrinologist, is imperative for the best clinical outcomes. So coming to the preoperative investigations, generally when they are admitted under endocrinology, they are evaluated for MEN1, so parathyroid, pancreas, pituitary tumors are ruled out. Then specific tests are done like cortisol, ACTH, TSH, C-peptide, insulin levels, growth hormone, prolactin, gastrin, PTH. For us, preoperatively, we get done a full CBC, LFT, RFT, electrolytes, PT-INR, chest X-ray, ECG. We see for the glucose charting of the previous few days, how has it been in the morning, when has it gone down, when was it maintained, and what was continued, what was the diet, was the patient given any IV dextrose for hypoglycemia, that we take note of, and the medication chart we take note of. And then if indicated, a 2D echo. A detailed airway examination should be done for all patients, especially if they are obese. So coming to the preoperative orders, the patient is generally admitted already in the ward to manage the hypoglycemia preoperatively. So what we write down other than our routine orders is to continue a IV infusion of glucose. We say 5% continue, start 5% dextrose overnight. It can be started at the rate of around 50 ml per hour during the fasting period. Then we say to continue dextrose infusion while shifting the patient to OT. This is very important that the infusion should not be stopped while shifting the patient from ward to the operation theater. And we advise to shift the patient to OT on a trolley. Then your somatostatin analogs and diazoxide, it should be continued until the morning of surgery to prevent hypoglycemia during the handling of lesion in surgery. Then we see for the chart. So we advise that hourly blood sugar monitoring should be done overnight, and we see the morning sugars. We also advise to avoid any sedatives or anxiolysis at night, and patient should be taken as the first case in the morning to prevent hypoglycemia. So pre-medication with any sedatives is in the preoperative period should be avoided because it can mask the symptoms of hypoglycemia. So any sedatives preoperatively is a big no-no. Now coming to intraoperative anesthesia management, our plan will be general anesthesia because it is a laparoscopic abdominal surgery. If it's an open surgery or if you want for pain relief, you can also insert an epidural. We generally give general anesthesia. Then we've discussed pre-medication should be avoided, again emphasizing that. The induction agent of choice is propofol, and that is what we routinely use anyways. So what is written is that thiopentone can cause profound hypotension in patients on diazoxide because thiopentone displaces diazoxide from protein, resulting in an increased free drug concentration, thus leading to hypotension because diazoxide is a vasodilator. But anyways, now we don't use thiopentone, so this is just for knowledge purpose. And then we give fentanyl generally 2 mics per kg. If you have remifentanil available in your institute, you can also use that. Then for muscle relaxant, we can use rocuronium, atraconium, anything is fine. For intra-abdominal pressures, we should keep it below 12 milligram of Hg because high intra-abdominal pressures can cause hemodynamic derangements. The maintenance of anesthesia is done with volatile agents. You can also use a propofol-based TIVA, but we generally used oxygen air with sevoflurane or desflurane. So all our halogenated inhalational agents, they suppress pancreatic insulin release, which leads to perioperative hyperglycemia. So it is actually beneficial to us. So using inhalational agents is beneficial because we will be able to prevent slight hypoglycemia with the inhalational agents. However, no data exists to suggest that perioperative outcomes are any different between TIVA and volatile maintenance. So this is how the position is given. It's generally a low lithotomy position. So the patient is taken down and this is the lithotomy position which they have given. And these are the ports that have been inserted. We are doing glucose monitoring. So one challenge is that the screen is generally at the head end of the patient, as you can see here. So we have to move our machine to one side of the patient. Accordingly, we have to manage our wires and our circuit and be careful that there are no disconnections during surgery. So for intraoperative monitoring, routine monitoring, ASA standards, pulse rate, ECG, SpO2, NIBP, ETCO2, blood sugar monitoring, which we will discuss in detail, and IBP if arterial line is in C2. So since symptoms of hypoglycemia are masked under GA, a vigilant blood glucose monitoring and tight metabolic control are very critical. So it is suggested that arterial line can be inserted because first thing, it will give you an accurate sugar monitoring. Second thing, you can have a continuous BP reading and ABG and electrolytes. But we generally do not put arterial line for most of the patients. Only if indicated we put. Otherwise, for routinely we don't put for insulinomas. For all insulinomas, we don't put. So what we do about the blood sugar monitoring is that we do capillary blood sugar every 15 minutes after induction of anesthesia. We use the middle finger or the ring finger. And central line, we have not put in most of the patients. It can be considered in obese patients with a difficult IV line. So what we generally do is we insert a 16 gauge or 18 gauge EJV that we keep in place along with the peripheral axis. Then when the surgeon is now doing the tumor manipulation, that time there are sudden surges of insulin. So we increase our blood sugar monitoring sometimes up to 5 to 10 minutes also at that moment. And then we can again go down. So main thing is that dextrose titration is required. So the maintenance fluid that we start from the start of surgery, we generally put the patient on a 5% dextrose drip or DNS. And we adjust the IV dextrose infusion. We keep 25D ready. And then according to the sugars, we keep giving boluses of 25% dextrose to keep blood glucose between 100 to 180. If blood glucose drops below 70, then 20 ml bolus of 25% dextrose is given. If it is consistently staying low, you can start an infusion of 25% dextrose during tumor manipulation. Now, the surgical milestone is that after around, when the surgeon has removed the tumor, so after around 15-20 minutes, 10 to 15 minutes of the tumor removal, the surgeon will ask you that has the sugar come up? Are you able to maintain sugars without giving your boluses of 25D? That means, is rebound hyperglycemia coming now, which is a confirmatory finding of tumor removal. So this is very important. This we have to take note. Then the alert condition is when there is still persistent or recurrent hypoglycemia post-resection. This signals that either the tumor has been not completely removed or there is another tumor. So that is why the surgeon asking us that whether now there is rebound hypoglycemia or not is very important, because then he thinks about whether there is another tumor or has it been missed. So this is very important. And then once the removal of tumor is done and your sugars have come up and stabilized, you can do maybe maybe at every 15 to 30 minutes according to how much long the surgery goes on. And when we see how accurate is the blood sugar estimation from different samples, arterial has been shown to be most accurate, then venous, and then capillary. But in a normal healthy patients without any sepsis or any vasoconstrictions, generally all are equivalent. So we go for capillary blood sugar measurements. This is the tumor. As you can see, they are generally small and enucleation is done around less than 2 centimeters, small tumors. So they can be missed easily. And what else happens during tumor manipulation? So we discussed about the sugar part, the glycemic. Also during tumor manipulation, because there is abrupt insulin surge, there will be hypoglycemia. Now, hypoglycemia will also lead to sympathetic stimulation, which will cause tachycardia and hypertension. So this is another thing we have to be careful about, whether tachycardia, hypertension is happening, and accordingly manage. Then, sudden withdrawal of insulin after tumor removal can also lead to hypotension. This has been written theoretically, although we have not commonly observed it clinically. Now, suppose there is a continuous blood glucose monitor. Your patient has come with a continuous blood glucose monitor, and if the sensor or transmitter is on the abdomen or anywhere else that could be problematic perioperatively, the position should be changed well in advance of the surgery. Extubation is our routine extubation with neostigmine, glycopyrrolate, or sugammadex after your criteria for extubation are met, and same, we continue sugar monitoring. For post-op analgesia, what we generally do is injection paracetamol 1 gram IV, and we give a port site infiltration of local anesthetic, which is given by the surgeons. And if needed, you can give a block, or that is a tab block or a rectus spinae if needed. Generally, what we give is paracetamol and port site infiltration of local anesthetic. Now, coming to post-operative management, generally the insulin levels normalize promptly. So intraoperatively only they start coming down to normal because the tumor is removed. But complete metabolic stabilization may take several hours to days. So a post-operative ICU stay is recommended. That is what we do. We shift our patients generally to our ICU, and we do a frequent blood sugar monitoring. We use sliding scale for insulin to manage any rebound hyperglycemia which occurs immediately post-operatively. And if there are also chances of DKA, so we have to be careful in the post-operative period. And even after discharge, daily blood sugar monitoring should continue to ensure glycemic stability. A coordinated discharge planning should include referral to an endocrinologist for continued outpatient monitoring and long-term follow-up. So to conclude, enucleation of insulinoma requires close intraoperative monitoring and prompt correction of any rapid and wide fluctuations. And care should be taken in managing hypoglycemia in the preoperative period, fasting period especially, and hyperglycemia which may occur postoperatively. So this is the gist of it. Thank you.
It's nicely presented.
My references.
It's nicely presented topic.
Thank you.
Yeah.
These were some values of our patients. So fasting was less, then it went up after giving dextrose, then intraoperatively they reduced, then again came up. So this is for a few patients. Thank you.
Okay.
I'll stop my PPT now.
Yes.
Stop.
Yeah. Thank you, Isha, for that excellent presentation. Now, I request Dr. Preeti to share her slides, and I request Anita Shetty ma'am to please introduce her.
Next presentation is by Dr. Preeti Devalkar. The topic is PPUPS up anesthesia management of parathyroid tumor. Preeti is an associate she's an associate professor at St. GS Medical and KEM, additional professor, sorry, GS Medical and KEM Hospital. Over to you, Preeti. Achievements, actually the slide is not being seen. Can you show that slide, Preeti? The first slide. She is a PG teacher, mentor for fellowship course in pain medicine, and she has number of publications in index journals. Her area of interest is chronic pain, USG guided blocks, and difficult areas. Over to you, please.
Preeti ma'am,
Preeti,
please
you are-
unmute
Unmute
yourself.
yourself. You're not audible. Start again. Yeah. No, not audible, Preeti. Preeti, have you unmuted yourself?
Slides are not going ahead, Preeti.
But Preeti is not heard now.
No, we can't hear her.
Preeti, you
You're
can
telling
share it again and see.
you've unmuted me,
Join again.
Priyanka.
मैडम आपका आवाज आ रहा है अभी अभी शेयर कीजिए और आप बोल सकते हैं
प्रीति का आवाज नहीं आ रहा है.
नहीं आ रहा है.
She can join again.
Preeti, try talking now, then we will know.
You're unmuting me, Priyanka. Anita ma'am. You have to unmute Preeti ma'am.
I cannot do it. I think those.
The admin will have to do it now. So
Yeah, that's what.
anybody is there from
Just now that fellow was there, na?
Sam's? Yeah, yeah.
Janika. Yeah.
Shraddha, can you
No,
just tell him?
I'm. Yeah.
You can tell Preeti to join in again otherwise.
Yeah.
मैडम एक बार रीजॉइन कीजिए आप
So, Anita madam, can we till then discuss about the first chapter of pituitary, which we took for the pituitary tumors?
Okay.
If
There are
anybody
no
has
questions. There are no
Yeah, there are
questions.
no questions, but you can share your vast experience of doing pituitary. So, Goel must have done so
No,
many.
we have done lots of cases. But sir used to do that sublabial, not the endoscopic
Yeah.
surgery, actually. But I wanted to ask Unmesh, what will be your any specific analgesia blocks or something? Because when they're doing the pituitary surgery, there's a lot of noxious stimulation. So there's hypertension and tachycardia. So how do you manage that? Do you have specific blocks for those you give? Unmesh?
So infraorbital blocks they have been described. I have not
Which
given
one?
per se. Infraorbital.
Okay. What about
So that
sphenopalatine blocks and all that?
yeah, it is described, but I have not given. So
Acha. So how do you manage the intraoperative hypertension and tachycardia?
so
It occurs.
we give short acting opioids
Hmm.
and Loxicard and short acting beta blockers esmolol.
Okay.
So while the local infiltration just to blunt the sympathetic response, bolus doses of esmolol, Loxicard,
Hmm.
and remifentanil infusion. And also dexmedetomidine infusion before remifentanil was routinely being used
So now you
since
use
the start of
remifentanil.
the
Okay.
yeah.
And suppose if the patient
And
gets
blocks I have read in literature.
Hmm.
Yeah.
What did you say?
Blocks just read in literature, but not really tried.
Acha. Because
Infraorbital
pivotal blocks are, I think, relatively very simple blocks if we can
Yeah.
use those blocks. That's what. And any technique of anesthesia, because as you said, you want quick recovery and, a patient should be very clear-headed recovery in the post-op period to avoid any airway obstruction. So what do you usually do, Unmesh?
To prevent airway obstruction.
No, I mean, intraop, how do you give,
How
what
do
do you,
Have
yeah,
you changed your
So we
practice
use
from using
Yeah.
propofol and
Sugamadex or
dexmedetomidine
something like that?
infusions.
yeah.
Yes, and we give one loading dose of vecuronium. So by 1.5 to 2 hours, we directly reverse it with Sugamadex, and through throughout we keep infusions of propofol and dexmedetomidine.
Okay.
Unmesh,
So
as you said, you cannot give CPAP or it is not advisable to give CPAP post-surgery. So suppose if you have some airway
Yeah, for
obstruction, how?
first 6 weeks we have to take care.
Yeah, but suppose on table you have extubated this acromegaly patient and then which you were anticipating anyways, then how do you manage that? Like,
So high flow oxygen with a face, one is thorough suctioning, oral
and
suctioning,
yeah,
and then is high flow oxygen delivery by a face mask.
means you
okay.
use HFN, no?
But HFNO through mouth,
Yeah,
HFNO
yeah, that
through the
so you said high flow
oral
oxygen,
cavity.
na? So I said what you use. High flow means what?
yeah.
How much liters of oxygen?
So we just use a face mask.
Hmm.
But
Suppose
HFNO through nasal cavity, I don't know, ma'am. We
no.
don't think I can use.
Yeah.
But through oral
Okay.
cavity, if we can put HFNO, we can use that.
There is one
Acha.
question from Vidya Deshmukh. Good evening, all. Has anyone come across a pituitary apoplexy for LACS anytime? Any pointers? Anita madam, RD sir, Shweta madam, any opinion on this? I think,
Yeah, I have not come across it.
yeah.
It is
No,
known
I have
that
also
it
not
is.
come.
Huh.
Mm-hmm.
What about
So
Unmesh?
we can
No, madam, not seen.
listen to Vidya if she has any
Yeah.
experience.
Yeah,
We don't
that's
mind
what.
listening to Vidya.
Yeah. Vidya, you can unmute yourself. Please unmute Vidya Deshmukh.
Actually, I don't have any experience. It's just that we somehow have a case which is posted in coming week. So I thought maybe this panel can advise again about it. So this patient is come to OPD for assessment, preoperative anesthesia assessment, and she is near term, and she's already been worked up by the endocrinologist, and right now she is on Thyronorm, and she is also on steroids. So as general rule, we've told her to continue it on the morning of surgery, but then apart from this, anything else if the panel thinks that needs to be taken care of.
No. What I want to say is pituitary apoplexy. Why you are asked specifically about cesarean section following LSTS?
So this patient is a pregnant near-term patient, ma'am.
Huh.
She's more than 36 weeks, and
Okay.
she's been diagnosed as pituitary apoplexy
Huh.
earlier in her pregnancy, and she's already been seen and assessed by the endocrinologist,
Huh.
and she's already on thyroid supplements and is on steroids.
Acha.
So they are planning
And
to do the section and the surgery together. How it is?
so they're planning to do section first because
Yeah.
she's near term.
Yeah.
So pituitary surgeries they've not yet thought about,
Mhm.
but section they are planning to because she's near term in coming week or so.
So they're not going to. But you know what? Usually, many times it's an emergency, no?
Matlab, it's
Then what
not
is
an
the cause
emergency.
of this? What is the cause of this pituitary apoplexy, basically?
It was not
It,
mentioned in her pack, ma'am,
acha.
PSC at least, but
Okay.
she
No, but
was
I was
all.
saying that sometimes it's due to a bleed or something, then it becomes a
I know,
emergency.
usually the cause, but then
Is
it's
this
nothing
patient
like that.
PIH as well? Is she having PIH?
No, she's not. She's not. Surprisingly, she's normotensive currently, and thyroid function also is pretty decent with the supplements.
Hmm. Means basically her physiological functions are well preserved.
Well preserved with the supplements, obviously, with
Okay.
steroids and with Thyronorm.
Okay. So that means there must be some infection or something.
Must be.
Not more than a bleed,
And so
because you said
yeah, so when she is stable hemodynamically, I guess we have to just maintain the vitals stable even during the section. That's a very intraoperative. What all do we anticipate?
Means I wanted to ask whether we can give spinal for such patients.
So that's what I was thinking. The spinal should be the main. I mean, she's well preserved, वैसे hemodynamically. So should not be any contraindications, madam, right? Any
Yeah, and then the only thing
induced
the thing is
precipitous
whether there is-
hypotension, maybe.
Yeah,
no,
but
whether
with
they should
steroids,
have what about intracranial pressure? I'm saying.
Yeah, so
So, in
optics,
fact, madam,
now she
LP would
diameter
decrease
or
the intracranial pressure, wouldn't it? So,
but sudden drop in
No, but
Just
vein
rule out
sudden,
we can just rule out
yeah.
papilledema and give the spinal.
Fundoscopy, you mean to say?
So
Mhm,
optic
mhm.
now she diameter or fundoscopy can help to identify whether the spinal would be safe or not.
Yeah, because there is something
Preeti,
which
are
is
you ready?
causing a yeah. Preeti,
Yeah.
Yeah.
Shall I share my
So the-
screen?
Yes, please. Thank you for that good quick review on pituitary. We can continue with the talk ahead.
I've already introduced Preeti, so she can start. Preeti can start. Huh?
Yeah. Good evening, everyone. At the outset, I would like to thank SAMS and ISA Mumbai Metro branch for giving me this opportunity. So, my topic is today anesthesia management of parathyroid tumor. Endocrine surgeries have been on the rise since last few years. After thyroid diseases, hyperparathyroidism is one of the most common endocrine surgical disease. And the most striking electrolyte balance disturbance during parathyroid surgery is the imbalance of the calcium level, and it poses unique challenges to the anesthesiologist. Roadmap of my lecture will be like this. So we will start with the anatomy. So parathyroid glands are like four tiny glands. They are located on the posterior surface of the thyroid, two on each side, each gland weighing around 50 gram and measuring about 3 by 6 by 2 millimeter. These glands are so small, so sometimes surgeons get confused between this gland and the fatty tissue. And the main cells of this gland are chief cells and oxyphil cells. Chief cells secrete the parathyroid level. Then blood supply is by inferior thyroid artery, venous drainage into the superior, middle and inferior thyroid vein, and nerve supply is by the cervical ganglia through inferior thyroid plexus. So these glands mainly secrete the parathyroid hormone, and it may responsible for the calcium homeostasis through its action on the kidney, bones and intestine. On kidney, it causes increased calcium reabsorption, it causes phosphate excretion, and it potentiates the vitamin D3. So it causes the hydroxylation of the vitamin D3. Then in bone, it causes reabsorption and mobilizes the calcium. So mainly it stimulates the osteoclast activity. In the intestine, it causes the formation of 1,25-dihydroxycholecalciferol, and which stimulate the calcium absorption from the intestine. Then this PTH is regulated by the calcium, phosphate, vitamin D3 and magnesium level. So calcium mainly regulates it through the negative feedback mechanism. Low calcium causes increased PTH secretion and high calcium causes decreased PTH secretion. Then vitamin D3, it mainly acts on the parathyroid. It decreases the PTH gene expression. Then phosphate, it acts indirectly. Increased phosphate level causes hypocalcemia and further leads to increase in PTH secretion. Magnesium, it basically acts like a calcium, but at the severe magnesium deficiency, it causes the paradoxical effect and it decreases the PTH release. And why are we so worried about the calcium? Because in our body, mainly the calcium is around 1 to 2 kg. Out of that, 99% lies in the bones and remaining 1% is in the plasma. And in that 1%, there are three forms. 50% is albumin bound, 45% is ionized fraction, and 5% is non-ionized. So this ionized calcium is the physiologically active form of calcium. Normal serum calcium level is 2.1 to 2.6 millimole per liter. And out of that, ionized calcium is 1.12 to 1.32 millimole per liter. And calcium plays a major role in number of physiological actions, like it has an effect on the myocardium. It causes positive inotropic effect. It increases the vascular smooth muscle tone, stabilizes the cardiac membrane. It is effective for the neuromuscular transmission, and it acts as a factor 4 in the coagulation pathway. And calcium homeostasis is maintained by the parathyroid hormone, calcitonin, and vitamin D3. So what are the disturbances of parathyroid secretion? There can be either hypoparathyroidism or hyperparathyroidism. But we mainly deal with the hyperparathyroidism because these patients come to us for the parathyroidectomy surgery. So again, it is classified as a primary, secondary, tertiary, and ectopic. So primary hypothyroidism is because of the hyperfunction of the parathyroid gland, and it causes overproduction of the PTH. In 19% of the cases, it is because of the single benign adenoma. 4 to 5% of the cases, it is hyperplasia, and 1 to 2% because of the carcinoma. This patient can present as a part of Main syndrome also. So it can be either Main 1 or Main 2A. In Main 1, there will be 3P, pituitary, parathyroid, and pancreatic. And Main 2A, it will be like along with parathyroid, there will be medullary carcinoma of thyroid and adrenal tumor. In the secondary hyperparathyroidism, it is like the appropriate compensatory response of parathyroid gland to the hypocalcemia. So it is seen in conditions like chronic kidney disease, vitamin D deficiency, rickets, osteomalacia. So mostly these patients are managed by the medically, but only 4 to 5% of the patient, those are not responding to medical treatment, are posted for surgery. Then tertiary hyperparathyroidism. It is like after long-standing secondary hyperparathyroidism, the patient becomes autonomous. It continuously secretes the excess of PTH regardless of normal or high blood calcium level. It occurs mainly in the CKD patient after renal transplantation. So in the tertiary hyperparathyroidism, serum calcium, serum phosphate, and serum PTH all are high level. Then ectopic hyperparathyroidism. Here the secretion of PTH occurs by tissues other than parathyroid. It occurs mainly in the carcinoma of lung, breast, pancreas, and kidney. So mainly these patients are presented with stone, moan, groans, and bones. So in the cardiovascular system, there will be hypertension, shorted QT interval on ECG, prolonged PR interval. Neurologically, this patient will have mental status changes, depression, weakness, lethargy. Musculoskeletal system will show the muscle weakness, proximal muscle weakness, osteoporosis, pathological fractures, and bone pains. Patient will also have non-specific abdominal pain, peptic ulcer, pancreatitis. And renal, they will have renal stone. They will present as a nephrogenic diabetes insipidus like polyuria, polydipsia, and later on with renal failure. So on investigating this patient in biochemical test, you will get hypercalcemia, hypophosphatemia, hyperchloremia, hypercaluria, increased serum PTH level, increased alkaline phosphatase level, and increased serum magnesium level also. On ECG, there will be ST segment elevation, QT interval shortening, biphasic T wave, and J waves. And nowadays for main one, they are doing the genetic test that is called NGS exome genetic test for main one genes. Then for radiological investigation, there are many types like CECT neck scan, 4D CT scan, thallium technetium scan, or sestamibie scintigraphy. It is done mainly to locate the hyperfunctioning parathyroid gland. X-ray of hand will show the periosteal erosion, cystic lesion, and DEXA scan is done to rule out the bone density. Then mainly these patients are treated with the medical management to maintain the calcium level. But if these patients are not treated adequately or they are not responding, then they can go into the hyperthyroid crisis. This is a rare but life-threatening endocrine emergency. So there will be the increase in serum PTH level, serum calcium level will be more than 3 millimole per liter. So it is treated with first infusion of normal saline, up to 4 to 6 liter of the saline can be given. Then also we can give bisphosphonate and calcitonin. They causes decrease in the parathyroid hormone level, but these are the temporary measures. Then if the patient is not responding, then they are treated with the forced saline diuresis Here the Lasix is given. It inhibits the tubular reabsorption of the calcium. Then for malignancy-induced hypercalcemia, corticosteroid can be given. But these are the temporary measures. The parathyroidectomy is the only curative method. Sorry. Then these patients are posted for the parathyroidectomy surgery. There are different options of surgical choices. So bilateral neck exploration is the traditional surgical approach. In this case, all 4 parathyroid glands are accessed through an incision in the neck. It is like horizontal incision, like thyroid surgery, and mostly done in the cases of hyperplasia of multiple parathyroid gland. Nowadays, most of the surgeons are preferring the minimally invasive parathyroidectomy because of this is a targeted procedure. It utilizes the advanced imaging for localization of the tumor. So it needs only 2 to 3 centimeter incision in the neck. It causes minimum damage to surrounding tissues and nerves. It causes less pain and shorter operation time. And nowadays, the new method, that is a transoral endoscopic parathyroidectomy by vestibular approach, TOPIVA, is used. In this technique, basically the surgeon is doing taking the incision at the inferior labial sulcus. So there are 3 steps: hydrodissection, insufflation, and surgical phase. So surgeon infiltrate the saline with the diluted epinephrine subcute region, and then neck insufflation done by the carbon dioxide, and plane is created between the subplatysmal region and the strap muscle. And after that, surgical phase is most important. Surgeon will need absolute immobility that time. So this procedure can cause complication like pneumomediastinum, pneumothorax, or recurrent laryngeal nerve injury. But in the hands of good surgeon, this procedure is also feasible and safe, and it causes excellent cosmetic outcome. So what will be the choice of anesthesia technique? General anesthesia is the preferred method for standard bilateral neck exploration and TOPIVA surgery. In our institute, we generally put PVC cup endotracheal tube, but intra-op, they need the hyperextended neck position, and surgeons are operating at the neck region. So it is better to put the reinforced endotracheal tube, or if you are planning to do the neuromonitoring, then specialized nerve monitoring endotracheal tube, that is EMG endotracheal tube. And if you are doing the TOPIVA surgery, then nasal intubation is preferred with throat pack. We can also place the LMA, but we have to be very vigilant about the misplacement, and we have to prefer the LMA with the airway tube, that is reinforced airway tube. Then the regional anesthesia. For regional anesthesia, superficial cervical plexus block along with local infiltration of the incision coupled with conscious sedation is preferred. There are many case reports, they were saying that along with superficial, deep cervical plexus block can also be tried. But deep cervical plexus block is not giving any advantage over this technique, and it causes the complication like dural puncture and phrenic nerve injury. So it is better to do the superficial cervical plexus block along with local infiltration of the incision and coupled with conscious sedation. So it is excellent for the targeted minimal invasive parathyroidectomy. It is mainly used in patients with significant cardiac and pulmonary diseases, and where you have to do the early assessment of the vocal cord function. So basically here, it is a USG picture of the superficial cervical plexus block. We have to use the linear probe, keep it on the lateral side of the neck and go posteriorly till you see the beaking of the sternocleidomastoid muscle. Then in this plane, you have to infiltrate the local anesthetic. So for pre-op assessment and optimization of this patient, apart from our routine investigation, we have to do the calcium level. We have to target the safe preoperative calcium level less than 3 millimole per liter. Then volume status. Pre-op aggressive overnight hydration using 0.9% saline is must to induce the diuresis. Then along with calcium, we have to see for other electrolyte abnormalities like hypokalemia or hypomagnesemia. These patients are malnourished, albumin is on the lower side, so we have to correct it prior to surgery because calcium binds ionized calcium binds to the albumin and it affects the calcium level. Then pre-op, we have to do the indirect laryngoscopy to know the pre-existing recurrent laryngeal nerve impairment. If this is parathyroid is associated with the thyroid swelling, then we have to check for the airway deviation or distortion. And if the patient is having the secondary hyperparathyroidism, then we have to do the dialysis prior to surgery. For anesthesia management, for induction, we generally use propofol. If the patient is having impaired cardiac status, like in the secondary hyperparathyroidism, then etomidate is preferred. We have to use the short-acting opioids for pain relief. Then short-acting muscle relaxant like atracurium and cisatracurium are used. Mainly if you are planning to do the neuromonitoring, then for intubation, we use the short-acting muscle relaxant, and then for maintenance, we use the TIVA. So for maintenance, we can use either volatile anesthetic, desflurane with oxygen and air. Sevoflurane is avoided if the renal impairment. And for nerve monitoring, we will use the TIVA, propofol, and fentanyl or remifentanil infusion. For monitoring, apart from standard ASA monitoring, we have to watch the urine output of monitoring. Then if the patient having cardiovascular disease, then arterial line is preferred. We are mainly doing here the intraoperative recurrent laryngeal nerve monitoring. Here, basically, we are using the tube, which has a surface electrode. They are placed above the cuff, and we have to place this tube such a way that these electrodes are above the vocal cord. So when the recurrent laryngeal nerve is stimulated, it causes the contraction of the vocalis muscle, and then EMG is created. It is transmitted to the monitor, and we have to assess the amplitude and latency of that EMG signal. And for that, we have to again use the short-acting neuromuscular blocking agent at the time of intubation, and then maintain on the TIVA. Then patient positioning. These patients are prone for fracture. So right from shifting the patient from ward to OT table, we have to be very cautious. Then for laryngoscopy also, we have to be very cautious about the positioning. Otherwise, it will cause the fracture of cervical spine. Then during intra period, the position is supine with head up tilt with neck extended via shoulder roll. Head is stabilized by a head ring and arms are safely tucked by the side. So this head up position helps in gravitational drainage of the blood, and it decreases the vascularity of the gland. And again, the eye padding is must for this patient because surgeon is operating at the head end. There is a proximity of the surgical retractor, so we have to protect the eyes. Then intravenous access, we have to take preferably in the lower limb, but if it is secured in upper limb, then extension tubing should be attached properly. And for intraop management, again, we have to maintain the normocarbia. Respiratory acidosis causes unbinding of the calcium from the albumin, and it increases the calcium level. So we have to maintain the normocarbia. We have to maintain the active hydration to protect the renal function. Then intraop steroids are sometimes given to prevent the airway edema due to the airway handling there. Then if the patient is on the renal protection strategies like CRRT, then we have to continue that perioperatively. In this surgery, blood loss is minimal, but it can be increased due to the platelet dysfunction in the secondary hyperthyroidism, and we have to maintain the normothermia. Then during the surgery, most of the time surgeon use methylene blue. So we have to be very cautious. Those should not increase. Those should not be more than the 5 milligram per kg. Otherwise, it will cause false low SpO2 readings. Then surgery duration is unpredictable in these cases due to the difficulty in locating the gland. Surgeon may find difficult to locate the gland in some cases, and they send the sample for the frozen section. Oh, just a minute. Why this is happening?
Go back and check, Preeti.
Started.
The slideshow, yeah.
So if the surgeon is using methylene blue, then we have to restrict the dose less than 5 milligram per kg. Surgery duration is unpredictable, as I said, because of the frozen section and difficulty in locating the gland. And in this case, if the patient has a pre-existing muscle weakness, it warrants a smaller dose of neuromuscular blocking agent, but elevated calcium level can also antagonize the action of non-depolarizer. So we have to do the neuromuscular monitoring in these cases. Then intraoperative parathyroid hormone monitoring. So in this case, the parathyroid hormone has a very short half-life, like 3 to 5 minutes. So they draw the baseline sample just before making the surgical incision, and then post-excision 10 minutes after that they again remove the second sample. And if there is a decrease in more than 50% in PTH level, then it suggests the right parathyroid affected parathyroid gland has been removed. Then again for extubation, prior to extubation, we have to confirm the vocal cord mobility. Then awake extubation is preferred. It should be done when the regular breathing pattern with the adequate tidal volume and patient is having the good muscle strength with top ratio of more than 0.9. But though it is a awake extubation, we have to do it smooth way so we can avoid hemodynamic stress response, but because again it can cause the bleeding. So for post-op analgesia, multimodal analgesia with acetaminophen and opioid is done. Patient receiving the regional anesthesia, they typically require the less post-operative pain medication, and NSAID should be avoided if the patient is having renal functional impairment. Then what immediate post-op complication can happen? Patient can have hematoma. It will cause the rapid neck swelling and leading to airway obstruction. And before shifting the patient from the recovery area, we have to check the dressing. And if there is a hematoma, it will need immediate bedside decompression. Then recurrent laryngeal nerve injury. If it is a unilateral, patient will present with the hoarseness. If it is a bilateral partial recurrent laryngeal nerve injury, then unopposed adduction of the cord will cause acute airway stridor. So endotracheal intubation is required here for temporary relief, and tracheostomy will be needed for preventive measure. Then another complication patient can have the soft tissue trauma and edema, and it can progress to further bullous glottic edema and causing airway obstruction. Then metabolic abnormality. Generally, hypocalcemia develop on second or third day, but if the patient is having other electrolyte abnormalities also, like hypophosphatemia, hypomagnesemia, hypokalemia, patient can have catastrophic symptom during immediate post-op period also, and we have to correct these abnormalities immediately. Then for respiratory obstruction, again, patient can have a respiratory obstruction because of hematoma, bilateral recurrent laryngeal nerve injury, glottic edema, and metabolic abnormalities. Then what is a hungry bone syndrome? It is a sudden massive calcium shifting into the bone matrix following the parathyroid or thyroid surgery. So if the patient is having persistent hypocalcemia for more than 4 days post-operatively, along with hypomagnesemia, hypophosphatemia, and normal parathyroid hormone level. So patient will present with the carpopedal spasm, circumoral paresthesia, positive Chauvet sign, numbness, tingling, severe muscle cramps, and cardiac arrhythmias. And here we have to correct the hypocalcemia by giving 10% of calcium gluconate 10 ml over 10 to 20 minutes slowly. So to conclude, the takeaway from my lecture is parathyroid disorder can present with a diverse clinical manifestation. Our primary goal should be hydrate the patient well and normalize the serum calcium preoperatively. It needs we have to coordinate with the surgeon for the muscle relaxation using the nerve monitoring, and we have to be very vigilant in the post-op period also. And patient can develop hematoma and nerve injuries. And post-op period, we have to monitor the serum calcium level to prevent the hypocalcemia. So management of these patients require multidisciplinary approach. It will cause safe and optimal management of the parathyroid disorder. These are my references. And July is the parathyroid awareness month. So if after this lecture you are feeling tired, then please go and check your calcium level. Thank you.
Thank you, Preeti. It is great. It is great to have Dr. Sameer Rege with us. Sir is joined. He has a busy schedule. So welcome, sir. Welcome on this forum.
Thank you.
Yeah. So he's an
He's our
excellent.
endocrine surgeon.
Yes, he's our
Shraddha?
endocrine surgeon. He's an excellent in his clinical judgment, technical mastery, an absolute wonderfully great laparoscopic surgeon, and he is an absolute adrenaline surge. The moment he walks in, all adrenalines have to start secreting. Am I right, sir?
I don't know whose adrenaline secrets, mine or yours.
So, he is the first one to do the endoscopic thyroid by transoral technique in West Zone, and probably RD sir, were you there when he did that first with?
Yes. I was there only.
Yes. So, what do you expect from? You have so many anesthetists, so you can put all what you expect from us when you're doing all this complex surgeries, Sameer sir. So, what do you want?
Basically, endocrine surgery is, I personally feel when we talk about endocrine, we see a lot of different things. Thyroid, parathyroid, I agree with what I was just hearing Preeti's talk. Personally, I think for all endocrine surgeries, anesthetists play a major role than what we do, because the repercussions of the same surgery are in different manner and cannot be interpreted only surgically. So when we talk about, just now I finished one robotic adrenal, but usually they have to be maintained with hemodynamic stable during surgery. And as soon as the clip on the vein goes, I think the drugs what were given, the exact reverse drugs have to be maintained with a lot of infusion. So they have to be on toes. So most of the things usually a surgeon would not interpret because we hardly see what goes behind the scene. And I think there has to be a collaboration between a surgeon and an anesthetist for betterment of patient, because then only the anesthetist is going to understand what exactly things are going to change. Because we have to tell them they are just infusing fluids or changing whatever the medications. But until we both go together and not in tandem, then only the patient is going to benefit. Other most of them, when we talk about, she spoke about recurrent palsy. So there are many times it may not be just recurrent palsy. It may be out after doing the last thyroid. The last thyroid is right now holding the entire trachea patent because it is holding because of Bayes ligament. Once you remove, even it may be just a transient trachomalacia, which usually gets reverses immediately. Most of the times, we have seen that we usually walk out of the surgery and nobody is there with patient. So personally, they also have to understand that surgeon has to be there, because it may not be there may be a senior anesthetic extubating, but what goes wrong that time, that it has to be jointly thought, because it may not be always recurrent. It can be this tracheomalacia which can cause stridor, and appropriate intubation at that time is important. When she talk about parathyroid, it's not a very easy intubation, because you cannot extend the neck because the bones are fragile, and they can have the maybe cervical injuries, spine injuries, because of extensive problems, because they can have fractures there. So these things have to be thought. There are many perspectives to it. Endocrine surgery, personally, it looks like this small gland comes out 1 centimeter, but it can have repercussions of the entire body.
Yes. Sameer sir, how do you choose? Any questions from the chairpersons? RD sir, you want to ask
Yes,
something?
I would like to ask Sameer. Yeah. Sameer,
Yes,
can you do the insulinoma in single port?
Sir, insulinoma is and there are two things in insulinoma. Firstly, you require to understand the localization. It may not always be on the surface. It can be at the head of the pancreas, can be body or tail. If it's at the body, at the tail area, you may be able to enucleate. But basically to understand that when we are using laparoscopic surgery, we are working at the fulcrum of abdomen, and it is not going to be easy, because our all energies are going to go in a perpendicular manner, and we do not want injury either to the duct, neither to the deeper vessels as a splenic vein. So the localization and the site of the insuloma would depend what exact approach would be. So many times we have opened directly because of its uncinate process mass. It may not be easily amenable for laparoscopic surgery.
Now, what is all about intraoperative USG?
Oh,
To
so
locate,
So this
so it,
endoscopic RFA which has been talked
yeah.
about, is it
So
available with us? Are we doing it?
no, we don't. We haven't. The best confirmation of site would be only endoscopic ultrasound if you're doing laparoscopy or intraoperative ultrasound. Rather, so basically there are two things. One is localization, and you should know a complete excision without damage to any pancreatic duct. That can be only denoted by endoscopic ultrasound. So a way to do is what we do is we try and localize with good amount of CT scan and DOTA scan, confirm that it is there. If it is very near the, it's in head or body, near neck, and it's near the duct, we at times put a stent in it, in the pancreatic duct, and then try and enucleate. But then the chances of having a pancreatic fistula are higher. Now, if you have an endoscopic ultrasound, you will understand you have completely removed it, because when you are going with the laparoscopic instrument go in tangent, and to excavate or enucleate the entire the insuloma from down may be not easy at times. But RFA, I would not choose for. So if there are multiple and the patient is really comorbid, then those things are preferred. But if it's a single, not very comorbid and with good anesthetists like you all, personally, it should not be a problem to take the insulin out.
and Samir, for
Yes, sir.
ectopic parathyroid, which
Again,
is in the
all
mediastinum.
so the first is localization. If you have a good system scan and a 4D CT, so nowadays 4D CT is preferred to understand localization, and system for pickup of the parathyroid gland. So if you have a good localization, it is very easy. But then again, you have to decide where your that parathyroid is, because it will be in and about the arch of aorta or its branches. So you should have a good surgeon to understand which side to enter into thorax, or direct do a mediastinoscopy to take it out. Doing per oral or transaxillary may not be very easy to take out a mediastinal parathyroid.
And what about VAT?
So VATS is possible, but only thing you require to
Thoracoscopy.
understand if it's on right or left side, and that side you approach. Left side is not very easy because the arch of aorta is going to come there, brachiocephal is going to come there. So, but if you are doing from right side, maybe yes, but then you require to have bilateral ICDs. Again, this laparoscopic
And
instrument
what is
rigid. So all endocrine, this parathyroid insuloma, adrenal, you should not break the gland because it will cause recurrence of symptoms. So all these instruments are rigid and will cause sharing of the capsule, which will in turn cause dissipation of cells and cause recurrence of problems.
The surgical skills are very, very important for
Yes.
maintaining the vital.
So the dictum would be: do not hold the gland, do not handle the gland, rather handle other. So the tumor, instead of taking out tumor, you take up the patient's body part away from the tumor. So do not hold the tumor at all.
Okay.
So how do you choose which patients would you do it like this, basically a parathyroids, which would you do on the local blocks, like, and which would
Personally, I
not?
would not prefer.
Okay.
Personally, I would not prefer in blocks because see, nobody is going to give me a gold medal. I would like
Yes.
my patient to be comfortable, and if patient is comfortable, anesthesia is comfortable, then I am comfortable.
If there are
So
multiple
question is,
means.
yeah, see, whatever comorbid, personally, my personal opinion is that general anesthesia is always the best safe for a patient. So at least the ventilation is secured. I don't want the patient to move and then I cause some recurrent nerve injury and patient has an injury for entire life. I would not prefer that.
Sir, are you monitoring recurrent now frequently? Maybe it is not possible in our setup
Uh,
because the tube is
yeah,
very costly. How about the,
the tube is 10,000 rupees. You
yeah,
require monitors also.
yeah.
I have no experience on it, but I had been to a center where they routinely do, but that is in Europe. But otherwise, it is not possible to do. Though maybe with medical legal everything, it will just pile up. But actually it's safer to do. but it's basically the dictum is previously used to be that you should not see the nerve, but now the dictum is you see the nerve, identify the nerve, entire course, and then only proceed at that. That means you have salvaged the nerve.
Okay. Thank you.
Shraddha, can I ask one question?
Yes,
Uh,
ma'am.
if pre-op there is continuous hypercalcemia, how do you manage that, Samir, in the pre-op before you send the patient to anesthesiologist for fitness? Many times in parathyroid, we do see high calcium, isn't it?
Yeah. So basically, I forgot that track. Usually, our solution is very clear. We become the carpenters, and the masters are the endocrinologists who will tell us that you cannot, you could take or you should not. So that is a usual term, but I'll tell you a medicine which is there. So people try and control hyperparathyroidism with those medicine if somebody is really comorbid, or they have not tried to. They even with attempts they have not tried to exactly localize the adenoma. But it is still better to have a good 4D CT scan to localize it with a assembly overlapping to confirm and try and take it out.
But any cutoff, calcium level cutoff that you think that beyond this, we will not take up the patient, we should wait or something like that. Do you have that in mind?
No, basically,
Do you follow?
no, basically the patient. So patient has to be hydrated well. That is number one. You can give a dose of maybe potassium along with it. And I'll tell you, I forgot that, but that can be given, which has to be discontinued just the day morning. So till that time, you then only you can take the patient. But personally, it should not be more than the 11 or 11.2.
Okay, yeah. Thank you, Samir.
Yeah. Any more
Thank you.
questions? Yeah, there are two
Which
questions in the chat
cases
box.
cannot operate? Samir,
What? Sir.
which case cannot be operated? Parathyroid.
Sir, I think if you are suspecting malignancy and there is erosion of bone, you can, but you have to explain them that patient would require permanent tracheostomies because they can infiltrate into the tracheal rings. So that those are really dangerous because then in bargain you're going to take out recurrent also and take out trachea also. So those things you require to be wary that you can have problems.
Okay.
Any more questions from the audience, please? We have few in the chat box. It is for Unmesh. Kindly give pointers on managing extubation in patient of pituitary to balance smooth extubation versus risk of aspiration in difficult airway with a nose packed. Somebody has put all things for you.
Tell us the extubation.
Nose is going to be packed that way achieved that the patient is able to gag. You can just extubate, and with the advent of Sugamadex and dexmedetomidine, I think extubation has become easier in especially in these patients.
Anita,
So
madam,
yeah,
you are there, right?
Yes, yes.
Yeah.
No, as we said, I think Sugama dance is a game changer because the patient's extubation is very smooth, clear-headed, and basically they cover their tone power very well. So they maintain the airway also.
So do
Unless,
you
of course,
recommend shifting to Sugamadex now?
Yeah,
Like it's
I
the time
think
to
so.
change to Sugamadex
Yes,
now?
yes, definitely. Yes, definitely. Only thing we have to remember, we have to give vecuronium or rocuronium
Yeah.
to this patient. And of course, unless the patient is deep with inhalation or TIVA, then you have to wait.
Ma'am,
But from
any
the master
experience with you
with Sugamadex,
with any experience when we did not have Sugamadex, where you had to put in a LMA and probably done the case in LMA? Any
we
experience
have to
with
do the
that?
case in LMA or we have to even re-intubate sometimes because of obstruction, especially if the patients are with acromegaly and all.
Yeah.
Like, if the reversal is not adequate or proper, they can get obstructed. So we had even a patient with negative pressure pulmonary edema also because of obstruction. So basically the patient has to be well reversed. That is very important in this patient. And of course those, Unmesh, what are they called? They do those packing with the nasal packing with the this thing, opening. What is it called? I forgot. Unmesh,
what they put some vasoconstrictors, no?
No. This
Oh,
packing,
they
where
get
they
that
don't
ready-made
yeah,
ones.
where
Aerosol.
nasal patency is maintained. Vidya,
Yeah, they have that
Merosil,
cup.
ma'am.
They have the
Merosil.
cup.
What is it called?
Merosil, ma'am.
Okay, okay, okay.
Yeah.
So those can help actually. If you suspect that patient can have airway obstruction in the post-op period. The main worry is airway obstruction in these patients. And Unmesh, one more thing I wanted to ask is about end-tidal carbon dioxide. Because they said slight hypercapnia is better in this patient, so they know the pituitary comes down, it's better access to the pituitary. What do you say?
So we maintain it around 30 to 35, unless
Okay.
the surgeon specifically asks for particular value. Otherwise, 30 to 35.
Okay. But do the surgeons ask sometimes they want little bit of higher side EtCO2? No.
No, not really. No, nowadays, no.
Acha, okay.
Preeti, there is one question for you. It was an intermediate cervical plexus block, which you showed. For USG guided, is this approach preferred?
So basically, cervical plexus block, there are different techniques like superficial, intermediate, and deep. So superficial is only subacute infiltration. Intermediate is when the investing layer of the deep cervical fascia is pierced. And then for deep, it is like prevertebral fascia is preferred. But for USG guided technique, generally we prefer this technique like beneath the beaking of the sternocleidomastoid, local is infiltrated, and this is used. And it is commonly labeled as a superficial cervical plexus block. But ideally, if we see that terminology, then it is mainly the intermediate. But for USG guided, we generally call it as a superficial cervical plexus block only. There is hardly any distance between subacute infiltration and then infiltrating beneath the beaking of the sternocleidomastoid.
Samir sir, can you please on your video for some time? We can have all the faculty today. Yeah, any more questions from anyone, please?
No, I just wanted to ask one question.
Shweta
Shraddha,
madam, can
whether
you
if
put
the-
your video, please? Yes, Anita madam.
No, I said if this, suppose this parathyroid patient comes for some other surgery, suppose it's for a hernia or lower limb surgery, will you give spinal, Preeti?
Ma'am, we can see the calcium level. If other parameters are okay, then spinal will be preferred for this patient.
Okay. No, I was thinking of from the point of view of, that, bones and all are very distinct, no? So fragile.
Okay.
So that's why I was asking.
We have to be very cautious
You
while
can give
positioning
USG
and
USG guidance.
Yeah, so thank you everyone.
only position is very important.
Yeah.
Any
You have
more
to be
questions
careful during positioning, I think, for these patients.
from the participants? Any more questions, please? So thank you everyone. We had a wonderful session this evening. Thank you for sparing our time. Thank you again for SAMS Maharashtra and ISA Mumbai Metro for providing this platform. I thank all the chairpersons and the speakers.
Thank you,
Thank you
Shraddha.
for your wonderful narrations. Thank you.
Thank you to the
Thank you,
speakers. Wonderful
Shraddha, for
presentation, and thank you, Shraddha.
inviting me from
Thank you.
SAMS
Thank you.
And thank you, ISA Mumbai, for giving us
ISA
this
Metro.
opportunity.
Thank you.
Yes. Thank
ISA
you.
Mumbai, thank
Thank
you.
you.
And SAMS.
Thank you very much.
Yeah.
Thank you.
Thank you.
Thank you. Thank you, Samir sir, from your busy schedule.
Special
Many
thanks to
Special
Samir.
thanks to you.
Yes, yes.
Thank you for
Thank
inviting
you,
me.
sir. Thank you, sir.
Thank you.
So we are waiting to see you many more. Thank you.
First, many more first.
Many more first.
I hope.
Yes,
correct.
sir. And we too want to be
Thank
part
you,
of your many
everyone.
more first.
Thank you, everyone.
Thank
A very
you.
good
Thank you.
presentation.
Thank
Very
you,
good
sir.
presentation.
Thank you,
Yeah.
sir.
thank you, sir.
Welcome.
Thank you. Good night, everyone, and
Good
happy
night.
night.
Good night. Yeah.
Thank you.
Good night.
Thank you.
Okay.
Thank you.
Long live ISA.
Long live ISA.
I say.
Yeah.
Thank you.